Welcome, welcome, BIO201. Yeah, this is the last lecture. I laughed and I'm like, holy cow, 8 weeks like that. So, getting a drink of water here. Hopefully, everyone's learned a lot this semester. I've enjoyed it, and there's still more to learn today. But before I get started with, continuing on with the nervous system, start with lecture and continue on with the nervous system. We're not going to finish the nervous system today. Of course, the nervous system is a humongous chapter. I mean, I took a whole class just on the nervous system. so it's a humongous chapter. So it's a humongous topic, I should say. So we're not going to, of course, cover it in 2 lectures, but hopefully you get the very big points. Like you should already know a significant portion of what the brain does, right? So, and what the different parts of the brain do, and how the brain functions and the cerebral cortex and all that fun stuff. Most people think, oh, when someone says, well, you don't use a large portion of your brain, you're like, no kidding, you use mostly cerebral cortex, the outer quarter inch, right? Everything else, not everything else, but a lot of stuff on the inside is the wires, the white matter, right? And we talked about deep inside, you still have nuclei like the diencephalon, hypothalamus, thalamus. Talk about all that cool stuff. So brainstem, cerebellum. So really neat stuff you learned, and we're going to continue on the nervous system today. So that is the plan. But like always, before I start a lecture, I always ask, does anyone have any questions in regards to anything before we start? No one has any questions. All right. Very cool. As you know, you have your finals this week. Of course, you should have already had this scheduled. I've mentioned it week 1. I must have mentioned it 5 more times since, to schedule your exams early so you don't have to panic to get them scheduled. But yeah, it's on you now, getting them scheduled. Last exam there. So yes, Amber, question, Amber.
Yeah, on the final, what chapters do we need to study more? I read a little bit on your announcement.
Yeah.
So you said there's a few questions on chapter 15. So what?
I think, did I mention that last time, Nicole? So I don't have to go into the grades exams and look at the event. Did I mention, was it like half?
I think that was for, I think it was 202 that we looked at. Yeah.
All right, that was 202. All right. So let me go in and look then. I just to kind of give you an idea. Of course, I'm not going to tell you what's on the exam.
I mean, we wouldn't mind if you did. That's fine. We won't be offended.
Well, I think those questions are like, who is your favorite teacher at CAC? That's pretty obvious.
So Nicole, are you taking 202 at the same time?
I am.
How is 202? What's on 202?
So it's very similar structure to this class if you're going to take it online with the same instructor, obviously. But it's a lot more about like function and how things work than it is about just like the gross anatomy and memorizing that kind of stuff. So I've enjoyed it because it's more about like how your body works, but it's not as much of like the just memorizing parts of it, if that makes sense.
Oh, okay. Yeah, I almost took 201 and 202 at the same time. I just didn't know if it was easier to take it one at a time or both.
No, don't do that.
Oh, both?
Yeah, no, it's way better to take one before the other, and you actually have to take 201 before you take 202. But I'm about 1 million years old, so in 2007, I took these classes before, so they allowed me to take them both at the same time, but it's only because I've taken both the classes before. But I'm going to let you know, I don't remember jack crack from 2007. So, yeah.
I feel yeah, I'm ancient too. Trust me. But I've never had to take these classes, not even in high school. So this is like, yeah, this is like all new to me. So yeah, I'm getting ready to take this next semester. So
yeah,
I did look at the exam just so I can answer your question. it is all nervous system. So it is, there's it's all nervous system on it. There's nothing on the census, on the census stuff. It's all nervous system.
Okay, awesome. Thank you.
Yeah. Sorry, you can continue, but I was just want to make sure I was just about to start lecturing. I'm like, wait, I didn't answer your question. So there you go.
No, please. We'll
Yeah.
take our conversation offline.
No worries. So it's all nervous system, and there's a few practical questions, right? What is this? What is that? But 80% of it is, multiple choice. So just without pictures. Only about, 20% of it or 15% of it is practical exam pictures. Okay. All right. So with that being said, let's continue on this wonderful thing called the nervous system. All right, so we talked about the brain, we covered the brain, and one thing I want to talk about is the protection you have around the brain. You have these things called meninges that are used to protect the brain, okay? That are used to protect the brain. And of course, the brain is very fragile because the outside of the brain is cerebral cortex, of course, right? Oh, so let me share my screen because you guys can't even see the picture I'm showing. That would make the class more challenging for sure. Share application screen, entire screen, yes, share. All right, so there it is. So you have this protection system for your brain. Okay. Now, is it 100% perfect? Of course not, right? Because people still get concussions, people still get brain trauma. But it is very, very good because every time you'd hit a soccer ball, you would have some type of cerebral trauma. Okay. But that is not the case because we have this protection. So of course, we have the skull. The skull is not part of the meninges, but we have technically we have hair. For some people, you have scalp, which is that if you remember that gala aponeurosis, that flat sheet of tendon that covers the skull, and then you have the skull, and then just beneath the skull you have a layer of fibrous connective tissue, and this is called the dura mater. So the dura mater is part of the meninges. The meninges are made up of three main portions: dura mater, arachnoid mater, and pia mater. Okay, so wrong one. So the dura mater, there's two layers of it. It's this, here's a skull. It's this thick connective tissue. Okay, and they have veins that travel in dura mater. You have you have something called superior sagittal sinus. I'm not going to talk about. It's a large vein. We'll talk about them about BIO202 when we talk about blood vessels. So this is this thick dura mater. It's a thick connective tissue. Everyone learns this. Dura mater means tough mother in Latin. So I'm just going to pass on that worthless knowledge. But every single time anyone goes over anatomy, I always say that. So I might as well add to it. So dura mater means tough mother. That's how you're going to remember. And it is a strong connective tissue sheet. Okay. So just to kind of give you an idea. You go to Google. Come on, how hard is it to type in Google? It is hard when you don't have my glasses and I can't see. So, excuse me. So when we look at it here, this is the dura mater. This here is a skull. Just beneath the skull is this thick connective tissue called the dura mater, and you have vessels that travel in the dura mater. And it's kind of interesting to show this middle meningeal artery. See this middle meningeal artery? I talked about this once before. See that middle meningeal artery? Does anyone remember when I talked about this artery? It goes all the way down underneath. It goes underneath the temporal lobe. I'm sorry. It goes underneath the temporal bone, and up through the parietal bone here. Does anyone remember what's so important about that middle meningeal? Oh, no. Yeah, I did talk about that middle meningeal in this class. Yes, I did. And remember, I told you this a long time ago. Which is the thinnest portion of the skull? And that is this temporal bone area right here. Okay? It's the squamous portion of the temporal bone. And if you get hit on the side of the head, the skull, the temporal bone, can go in and cut that middle meningeal artery. And if it cuts that middle meningeal artery, you get a subdural hematoma, which the person can die from because you have internal bleeding in the brain, right? And the bleeding builds up and it puts pressure down the brain because there's no room to move, right? Because of the skull, right? So that's why many people, or you hear about people that die from getting like hit on the side of the head due to trauma on the side of the head. It's quite often it's that middle meningeal artery because the temporal bone right there is very thin. I mentioned that to you. So I mentioned also, right, the frontal bone technically is very strong, but that middle meningeal is on the temporal bone is very thin. Okay. All right. So that is the dura mater. Just underneath the dura mater, you have this arachnoid mater. So let me show you this. So just here's the dura mater, and you see this little orange part here? That is arachnoid mater. It's not labeled, but that's what this should be. This is arachnoid mater. It's a little orange line. That's a thin little membrane. And then there's a space called a subarachnoid space. Subarachnoid space because it is beneath the arachnoid mater, right? Sub meaning below. This is a space here, subarachnoid space. And then below that, this is the gray matter here. Touching the gray matter is the pia mater. It's another thin membrane. So you guys are probably wondering, I understand how the dura mater can protect the brain, but how does this thin little membrane called the arachnoid mater and this thin little membrane called the pia mater protect anything? How does that protect anything? Well, the answer is it really doesn't. But what it does, it creates a space. And does anyone know what's found in the subarachnoid space? Anyone know? What do you find in that space? Something very important. You guys wrote it on your assignment. Yes, Mackenzie. What do you think you find in that space, Mackenzie?
Is it cerebral spinal fluid?
Exactly. Nice job, Mackenzie. Cerebral spinal fluid. Cerebral spinal fluid you find in that space. And that cerebral spinal fluid is a shock absorber. It is a shock absorber so the brain doesn't smash into the skull. So you have the skull for protection. Then you have the three meninges, dura mater, which is very thick and strong. Then you have this tiny little membrane, arachnoid mater, a space, then a tiny little membrane, pia mater. The arachnoid mater and pia mater do almost nothing, but they make a space. They contain this thing called cerebral spinal fluid. Cerebral spinal fluid is a shock absorber. So like I learned that your brain is kind of floating in this cerebral spinal fluid. So you have this cerebral spinal fluid, the subarachnoid space, holding the cerebral spinal fluid surrounding the brain. You see that? Surrounding the entire, of course, this just looks like the top of the brain, surrounds the whole entire brain. Now, where does the cerebral spinal fluid come from? It comes from these areas called the ventricles. The ventricles are large spaces in the brain. You have lateral ventricles, okay? Then you have a third ventricle, it's a space in the brain where it holds cerebral spinal fluid. Then you have a cerebral aqueduct, and then you have this canal called the central canal going through the middle of the spinal cord. This is where cerebral spinal fluid is made, in these ventricles. In the lateral ventricles and in this third ventricles creates the cerebral spinal fluid. Okay, so you have cerebral spinal fluid surrounding the brain, the subarachnoid space. Oh, by the way, it also surrounds the spinal cord. It surrounds the entire central nervous system. You have a subarachnoid space. Okay, and it also, cerebral spinal fluid is found in these spaces in the brain called the lateral ventricles the third ventricles, the cerebral aqueduct, and this technically it's a fourth ventricle here, and then down into the central canal. Okay. So let me go to Google to show you a picture of the ventricles. So this is actually what they kind of look like. Here are the ventricles. Okay, here's the two lateral ventricles, third ventricles, cerebral aqueduct, and then the fourth ventricle here. And then let's see if it shows it here. Yeah, you can see the ventricles here. Here's the lateral ventricles. It looks a lot bigger in that picture, but this is an MRI cross section. Here's the two lateral ventricles. Here's that third ventricle. Here's the cerebral aqueduct. Here's the fourth ventricle. Okay. There's another picture of an MRI. See this space in here? Here are the lateral ventricles. Okay, down into the third ventricle. You can't see the cerebral aqueduct in this one here, but you see it very well here. Lateral ventricles, third ventricle, cerebral aqueduct, fourth ventricles down in here. Very cool. Very, very cool. So now you know, look at how much you already know looking at MRI images, right? This is the gray matter. See the gray matter, this grayish portion on the outside? You see that? White matter on the inside, right? This is the thalamic region right in there. Here's a lateral view. You can see the lateral ventricles right here. There's two of them, one on each side. Two lateral ventricles right in there, right? Cool stuff. Looking at this. By the way, what am I pointing at right here? What am I pointing at? You guys know that. We just talked about it last class.
Is it the cerebellum?
Cerebellum.
Cerebellum, yes. And what is this that I'm pointing at right here? Let's see. The brainstem, very nice. Well, technically, the medulla oblongata is right there. Here's the pons, and there's the midbrain. Okay. Now there is something. Now that I'm looking at those MRI images, there is something I forgot to mention. You see this? Here's the lateral ventricle right there. Okay. So I know it says septum pellucidum because that's a split between this. There's like a little tissue between the lateral ventricles, but who cares? You see this here, just around the outside. Okay. This is called the corpus callosum. I forgot to mention this last class. This corpus callosum connects the two cerebral hemispheres. So these are white matter. These are wires, axons that go left and right. They go right into this, right, connecting this cerebral hemisphere, and it comes right towards you, connecting the other cerebral hemisphere. That's the corpus callosum. That is how you connect both cerebral hemispheres. Okay. So the reason why I mentioned that is because in this picture, that's number 2. Corpus callosum. There you go, the corpus callosum. All right. So here's another one here. Of course, lateral ventricles, third ventricles, right? Fourth ventricle. All right. So cool stuff. So you guys can look at MRIs. You already know some stuff in there. A lot of stuff, actually, not some. All right. So that is a protection system of the brain. Now, we're always making a little bit of cerebrospinal fluid. You're always constantly making cerebrospinal fluid. And cerebrospinal fluid is always leaking out slowly into that superior sagittal sinus. Oops. Always leaking out slowly into that superior sagittal sinus. So therefore, what that means is that you're always adding a little bit, you're always making a little bit of cerebrospinal fluid. You always have fresh cerebrospinal fluid is what I'm trying to say. You always have fresh cerebrospinal fluid. Now, is it a problem because it leaks into the venous supply, the blood system? It's not a problem because cerebrospinal fluid is A, it is sterile, and B, cerebrospinal fluid B is almost the same exact constituents outside of some items, but it's almost the same exact constituents as plasma. So it's not going to affect you whatsoever, okay? None whatsoever. So always making cerebrospinal fluid, and some of it is always slightly leaking out into your plasma. All right, so let's talk about the spinal cord. So we look at the spinal cord. Of course, it goes through the vertebral frame. This is a terrible picture. Please have a better picture than this. You do not. All right, maybe Google does, but we'll use this for now. You look at the spinal cord coming down. The spinal cord technically ends. I guess what vertebrae do you think the spinal cord ends at? So let's go with, let me ask you before I tell you.
L1
What do you
and
think?
L2.
L1 and L2, very good, because I mentioned that a long time ago. The spinal cord ends at L1 and L2. Okay. Oh, by the way, before I go any further, people watching the recording, what are the three meninges? And the answer, of course, is dura mater, arachnoid mater, and pia mater, the three meninges. So it ends at L1, L2 for adults, but it goes all the way down to L5 in children. It goes all the way down to L5 in children. Okay. So what happens after that? Well, this is what happens. See the spinal cord coming down? And then it breaks up into these ton of these nerves, spinal nerves. We call the cauda equina. So this is around L1, L2, depends on the individual, somewhere around L1, L2. And then it breaks up into the cauda equina. So a baby doesn't really have a cauda equina because the spinal cord goes all the way down to here, L5. Has a very small, I shouldn't say it doesn't really have it, has a very small cauda equina. And then as it migrates up, the cauda equina grows with it. Okay? So this is the cauda equina. Surrounding, of course, the spinal cord. You still have meninges. You still have the dura mater, arachnoid mater, pia mater. You have the subarachnoid space with cerebrospinal fluid. Now, when we look at the spinal cord, okay, the spinal cord has enlargements. Here's a decent picture of it. So if you look closely, the spinal cord will enlarge in the cervical region and enlarges in the lumbar region. It's called a cervical enlargement and lumbar enlargement. Okay, cervical enlargement, lumbar enlargement. It's actually at the bottom of the cervical. It's like C4 to T3 or something like that. But we call it the cervical enlargement and the lumbar enlargement. So it thickens. Why? Because you have a whole bunch of nerves that come from the cervical enlargement. See how it gets a little thicker there? And we call that the brachial plexus. So let me go plexus of spinal cord. So we call that the brachial plexus. So you see all these nerves coming from here? This is called the brachial plexus coming off of the cervical enlargement. And all these nerves, of course, you have intercostal nerves going every level. We have a ton of really thick nerves that come off the brachial plexus. And those nerves are what supplies your shoulder, your arm, your hand, your forearm, and your hand, right? That's what the nerves supply. So the brachial plexus is where the nerves that come out supply your whole arm and hand. You have a lumbar plexus right at L1. And then you have a sacral plexus coming from the bottom of the sacrum, where the sacrum is, a sacral plexus. So right down here is where your sacral plexus would come from. Let me get a, see if there's a better picture. No. So this is your sacral plexus here, coming through the posterior sacral foramen of the sacrum. Here's the lumbar plexus coming up all the way at L1, L2. And here's the brachial plexus coming from this area. Technically, it's a cervical plexus, but who cares? This is the brachial plexus. So number two's answer in this person's question would be brachial plexus. This is the lumbar plexus, and this is the sacral plexus. Okay? All right. So if we look at another picture, here's the brachial plexus right here. Now, the brachial plexus is broken up into trunks, cords, divisions. Who cares? Roots, trunks, cord divisions, technically, but who cares, okay? But what happens is brachial plexus will come down and will branch out into three big nerves. You have a radial nerve, an ulnar nerve, and a median nerve. Ulnar nerve, of course, on the ulnar side. Here's the median nerve. Here's the radial nerve, okay? See that? ulnar, median, and radial nerve. So let me kind of just show. So on the ulnar side is the ulnar nerve. On the thumb side is the median nerve, and the posterior arm is the radial nerve. We talked about the median nerve. The median nerve will go this way and go underneath that flexor retinaculum. What do we talk about the median nerve associated with? What condition? If it gets impinged or irritated underneath that flexor retinaculum, someone will get what?
Carpal tunnel?
Carpal tunnel. Carpal tunnel. So there's three main nerves: the median nerve, the ulnar nerve on the ulnar side, and the radial nerve in the posterior arm is the three nerves, the main nerves that come off the brachial plexus. There is a musculocutaneous nerve that supplies the shoulder. It's not shown here, but there is a musculocutaneous nerve that supplies the shoulder. Okay? So it's not a lot of nerves to really remember. Three main ones. Well, four if you can include the musculocutaneous. Big deal for the arm. Okay? Median, radial, ulnar. Okay? Pretty cool. All right, so the median nerve, thumb side, ulnar nerve on the ulnar side, and the radial nerve posterior. Okay? I know thumb side is radial. I didn't make up the names. This should have been better called radial nerve, to be honest with you. But I didn't make up any of the names. So that's how it goes. So if we look at here, it's just showing you the innervation of certain muscles by certain nerves. Not that important for us here, but all right. So, oh, I shouldn't have closed that out. I need to Google for more pictures, I'm sure. Oh, okay. All right. So let's get back to our PowerPoint. Oops, does someone have a question? Let's see. All right. So we went over the plexuses. Brachial plexus, lumbar plexus, sacral plexus. You have a cervical enlargement and a lumbar enlargement, thickening. We talked about the chordae equina. Okay. This is just showing if someone does a lumbar puncture, like if they need to grab cerebrospinal fluid. Of course, you want to do it in the lumbar, low in the lumbar spine, because there's no spinal nerve here. Oop, let's see what happens. Oh, let me show you a picture of that. That is your ulnar nerve, by the way. I forgot to mention that. Well, there's so much to talk about, right? Nerves of arms. I wish I had that picture up already. That goes around the medial epicondyle of your humerus. So you see this ulnar nerve? That's a good picture. It goes underneath the medial epicondyle, then comes around. So when you hit your funny bone, that medial epicondyle hits that ulnar nerve. So you start getting numbness and tingling on the ulnar side of your hand. When you have carpal tunnel, it's these three fingers on the radial side of your hand, because that's the ones that's supplied by the median nerve. But the ulnar nerve goes around the medial epicondyle of the humerus and supplies the fourth and fifth digit there. Okay. So another picture, you see that ulnar nerve going underneath and around that medial epicondyle. Should go on top of it, but that's not how we're made. It goes underneath. So if you hit your medial epicondyle, you affect that ulnar nerve. Okay. All right. So cool stuff. So a lumbar puncture, when you pull cerebrospinal fluid out, you always want to do it in the lower lumbar. Why? Because there's no spinal cord there, of course. So you're not going to cause a spinal cord injury. The way it could happen, you could affect a spinal nerve. You could damage a spinal nerve, but it's much better to damage one nerve than putting a hole through your spinal cord, right? Right? So less risky procedure. That's why they take it down there. Now, why would they take cerebrospinal fluid from the lumbar subarachnoid space? What would they use the cerebrospinal fluid for? When someone has a lumbar puncture, why would they do that? And why would they use down there? Well, use down there, I already told you, because it's fairly safe. Because that cerebrospinal fluid is in the chordae equina, not on the spinal cord. They would take cerebrospinal fluid, because I already mentioned it once. Cerebrospinal fluid is supposed to be sterile, sterile. And if it is not sterile, that means there's an infection. And where does the cerebrospinal fluid come from? Where is it made? Where did it originally come from? The brain. So that is how they diagnose a meningitis or an encephalitis, okay, is by cerebrospinal fluid. They don't have to put a hole through the skull and do it that way to find out what type of infection, right? To do some type of culture. They just culture the cerebrospinal fluid, and they take it from, because where did it come from? It came from the brain. So if it's not sterile, there's an infection in the central nervous system, most likely the brain. Now then they know what they're dealing with. Is it bacterial? Is it viral? What type of bacterial infection are we dealing with? If it is bacterial, what type of viral infection we're dealing with? Because there's both viral and bacterial, meningitis and encephalitis. Meningitis infection of meninges, encephalitis is actually infection of on top of the cerebral hemisphere, on top of the brain, right? The gray matter. All right, we good? We understand why they do that? Okay, so most likely if someone is diagnosed with a meningitis encephalitis, they're diagnosed because they've taken cerebrospinal fluid. Right? All right, and there's a lot of symptoms associated with that too. So, okay, we good? This is good stuff. Stuff you need to know. You will see. All right, so here's a cross section of the spinal cord. A cross section of the spinal cord. Okay, so if you look at a cross section of the spinal cord, there is something you see that is very different. What I see is very different. Here's the spinal cord. Is where's the white matter? It's on the outside. That's the tracks. Those are the wires. Where's the gray matter? On the inside. It's the exact opposite what you find in your brain. The exact opposite of what you find in your brain. Correct? Yep. White matter on the outside, gray matter on the inside. White matter, gray matter. Now, with that being said, let's talk a little bit more about this. You see the spinal cord? This is the subarachnoid space out here, right? The cerebrospinal fluid in there. This is fat, okay? Epidural fat means outside the dura. Epidural, subdural means inside the dura. Epidural means outside the dura. This is the dura mater, of course. So like I mentioned before, you still have me. Here's the pia mater right on top of the, see that pia mater? Right on top of the spinal cord. This is the epidural fat. Now, gray matter on the inside. See that little hole in the middle? That's called the central canal. That's spinal fluid is, cerebrospinal fluid is on the outside in the arachnoid, subarachnoid space and goes through that central canal. Okay. This is gray matter, and the gray matter, this is the anterior side, so the anterior horn, lateral horn, posterior horn of the gray matter. They look like little horns. Anterior, lateral, posterior. Now, here's a closer picture of it. See central canal in the middle? This is the gray commissure, the connection between the two sides of gray matter. Okay. This is the anterior and dorsal sulci. Anterior and dorsal sulci. Now, sometimes it's called the ventral median fissure, but I've also heard it called the anterior sulci and dorsal sulci. So whatever. You see these connections to the spinal cord? Let me kind of explain how this works. How do nerves, see the nerve here? The nerve is two-way information. It's efferent and afferent. And the nerve splits as it attaches to the spinal cord. Now, here we go. Sensory information. Someone touches your hand. Sensory information is going to go down. Let's say someone touches the inside of your hand where your ulnar nerve is. That information is going to go down the ulnar nerve. Eventually it's going to get to the brachial plexus, and the brachial plexus is going to attach to the spinal cord. See, here's the information. Look closely. Sensory information. Now it's going to split. Which way is it going to go? It's going to go down, we call the ventral root, and attach to the spinal cord on the ventral root. Okay, sensory information goes down the nerve through the ventral root. Now, let's say you're moving your hand, move the muscles of your hand. Motor information, look where it's going out, through the dorsal root. Now, there's something called a dorsal root ganglion. I don't want to get into that right now because then we're dealing with upper and lower motor neurons and all this other stuff. So I don't want to get into that stuff. So, all right. All right. So when we look at the spinal cord, okay, so let's just go over the spinal cord here for a second. A nerve carries two-way information. Motor information, I think I don't know. I think I missaid it earlier, but the ventral root carries motor information. The dorsal root causes sensory information. I think I mixed them up last time I had them. I'm thinking, what did you say? You said it wrong. The ventral root carries motor information. The dorsal root carries sensory information. This is where two neurons connect. I don't want to get into nerve connections here quite yet. Okay, and a spinal nerve carries two-way information. So when I want to move my arm, motor information goes out through the ventral root. When I get sensory information, it comes in through the dorsal root. Okay, this is how it's connection. So these roots are one way going to a nerve, which is two-way. So these are one-way streets going to a nerve that carries two-way information. Okay, and that is how the connection works. And eventually it'll come in and connect to the gray matter. All right. Now, let's talk about a spinal reflex. A spinal reflex, like someone hits your knee and your knee extends, right? What is that? And what is the doctor and nurse practitioner doing? And what are they testing for? Most people have no idea. Not you. You're going to learn that today. So you have some type of knowledge in it. So let's see. Okay. Yeah, so why do doctors do that reflex, and why do we have that reflex? That reflex is a protective mechanism. Your reflexes are protective mechanisms. Now, you have receptors on your tendons and on your muscles. So if you stretch a tendon really quickly, you will compensate by trying to contract that muscle very quickly. Why would you do that? Because you're trying to protect yourself, especially like tendons, like the patella tendon, from falling. When you trip, let's say you're walking, you're running, and you trip, you hit your foot, you're going to stretch that tendon. And what you will do is you'll try to contract your muscles or your quads to try to catch yourself, to balance yourself. Everyone's tripped before, and they try to catch themselves, right? That is a reflex. That is the reflex you're testing. There's a lot of other reflexes out there. We're not going to go into all the reflexes, but that is the reflexes you're testing. So, I thought I had a picture of it. I don't. So when you hit, let me see if there's a Google may have a picture for this. So when you stretch your tendon, here's a good picture. You stretch your tendon, you have receptors in your tendon and in your quads that when they stretch, you stretch it, okay, you're going to send sensory information. See, stretch receptors. See, here's a stretcher. You can send sensory information down the nerve. It'll go down the dorsal root. We just talked about that. Okay. And then it will go to it'll go into the posterior horn of the gray matter. Okay. It'll go into the posterior horn of the gray matter. It'll synapse with an interneuron, a neuron in that gray matter. And then what it'll do is there's two pathways now. It'll send out a motor neuron. It'll innervate with a motor neuron and send an action potential down the motor neuron to your skeletal muscle to contract. So you contract your skeletal muscle without even thinking. It doesn't even go to your brain yet. And then eventually you will send information up to the brain telling you you're tripping. But you will contract your quadriceps before you even know you're tripping. Fact. Because you will have a spinal reflex. Sensory information comes in, hits the dorsal horn, sensory information comes in from the stretch receptors, goes up through the dorsal root, goes to the dorsal horn of the gray matter. It'll innervate there with another neuron called an interneuron. And then an interneuron will do two things. We'll send information up to the brain, but it will also innervate with a motor neuron that'll send information out through the ventral root to your muscle to contract. And that is a spinal reflex. You will start contracting that quadricep to catch yourself from falling. And that is a spinal patella tendon reflex. Okay? That is what you're testing. You're testing to make sure this pathway is working. Make sure the spinal nerves are fine. Make sure the spinal cord is fine. And make sure, so the spinal nerve, the dorsal root, the spinal cord, and the ventral root are all functioning correctly in that area by that reflex. That reflex is not just for when someone does that reflex. They're not just, hey, look at this fancy, the leg kicks up. Ha ha ha. What does that mean? Right? You're not doing that to waste your patient's time or your time. You're testing those things. You're doing a neurological exam. You're testing the sensory receptor. You're testing the spinal nerve. You're testing the dorsal horn. You're testing the spinal cord. And you're testing the ventral root and then the ventral nerve as the motor information goes out. That is what you're testing. Okay? And the leg kicks up. So that is very important. That's called a spinal reflex. So that is what you are testing when you do a reflex hammer. So with that being said, believe it or not, when you trip, you're actually contracting your leg before you even know you're tripping. And if you ever happen, now that I've told you this, next time you trip, think about that afterwards, right? I actually contracted my leg before I even knew I was tripping. But it's only like a tenth of a second. But that tenth of a second can mean the difference between you falling flat on your face or you catching yourself. Okay? You put your hand on a hot stove. You do the same reflex. Of course, this is in the brachial plexus it happens, not in the lumbar plexus. You do the same. You actually pull your hand away a tenth of a second before you even realize your hand is burning. You've touched something hot. Yes, you do. You want to do that lab in class? Do not do that at home. I guess I should say that. Nowadays, I guess I should. So, very, very important. So let's see. I just tripped. This is correct. So it is a protection mechanism. And I know you may think, but it only saves you a tenth of a second. That tenth of a second, when you put your hand on a hot stove, can mean the difference between a first-degree burn and a third-degree burn, right? It can mean the difference you falling flat on your face or not, okay? But the more important thing is you're testing that conductant, that neuroconductive pattern, that spinal reflex. A spinal reflex. Now, I know what the question is going to come up next, where you should be thinking. The question is, what happens if it's bad? Right? If someone has cerebral palsy, multiple sclerosis, there's other ones, I'm sure, neurology. It's been such a long time since I've taken my pathology class, neuropath, that is. But you have a problem with this connection system. So someone with multiple sclerosis will have a problem with it. What does the problem show us? Not having because sometimes you just don't hit the tendon hard enough to cause this reflex to happen. So if you do a patella tendon reflex and the person doesn't kick their leg, that's nothing to really worry about. You probably made a mistake not hitting the tendon. What you have to worry about is multiple reflexes. This is very important. I've seen this, and I knew it was a problem right away. I've seen this, and I knew it was a problem right away. Multiple leg extensions. Why? Because this is supposed to go through once if there's no problem. Or someone has multiple sclerosis, you have damaging of the myelin and you have short circuiting. So it happens multiple times, and they have like multiple like tremor reflexes, 1, 2, 3, like reflexes from one tendon. You see that happen. That is a you send it out to a neurologist at that point, right? That is significant. Right? Or they already may know, the person may already have one of the neurological issues. So it's like, okay, that makes sense. Okay, but that is what you're looking for, multiple reflexes. Okay, are we good with that? Important to know. You may be the person that this happens to, right? Are you going to know what to do? You're like, hey, I remembered A&P. This is significant. I need to follow this up, right? Or you could be like, oh, you had 2 leg extensions and no big deal. It is a big deal. Let me tell you something that just happened just this week. My wife's a doctor, okay? And of someone messing up badly, and just because of lack of knowledge. My wife had a patient that went to the ER, had eye pain, and they were like, oh yeah, the ER person looked at it and said, oh, you have a corneal abrasion, you need to go to the ophthalmologist. So the person then took a couple of days to go see the ophthalmologist, and eventually got to my wife. My wife said, this isn't a corneal abrasion. Okay. And the person was misdiagnosed. Okay. And what the person ended up having shingles, that the shingle pattern follows the dermatome pattern when it goes into the person, that covers the pattern that covers her eye. So, which is significant because you can go blind if shingles get really bad in your eye. And now my wife's trying to fight to save this person's vision. If the person would have showed up a couple of days earlier, would have been easily solved. But now it's fortunately the person is getting better, but it was a very touch and go for a couple of days because of a simple misdiagnosis of something that should have been picked up, something as simple as shingles. Yes. It was just misdiagnosed because the person didn't know what shingles, probably didn't know what the symptoms of shingles. Oh, it's probably just corneal abrasion. Go see your doctor in a couple of days if it doesn't go away. And it kept getting worse, worse, worse. And by the time I saw my wife said, this isn't a corneal abrasion, it's shingles. And I had to really work hard to save this person's eye from going blind. That is the importance of understanding A&P or pathology. It's probably the 2 biggest classes you'll ever take, right? So, just so you are aware, I told you this day one, your biggest weapon as a healthcare practitioner is what's between your ears. I'm telling you, it is so true. You're either going to be a person be like, I just do what I'm told, or I understand what's going on. Like, that is not a corneal abrasion, that is shingles, right? Or this person has multiple spinal reflexes, and you're like, oh, it's probably not a big deal. You're fine, right? Or be like, no, this is a big deal, right? Okay. I'm just telling you, it's the real world, right? One day you're going to get out of school and you'll be in the real world, right? All right. With that being said, let's move on. I guess I got my little soapbox rant there. So for the recording, what are the different parts of a spinal reflex? Well, the different parts of a spinal reflex for the recording, okay, is you have the receptor, the stretch receptor in the quadriceps. You have them in tendons as well. And then you have your sensory, the stretch receptor will lead to a sensory neuron that will go through the dorsal root. So stretch receptor, which is a sensory neuron, which goes to the dorsal root, number 2. Number 3 goes into the gray matter. And then it'll meet up with an interneuron. That's number 4. Number 5 will then go to go through the ventral root through a motor neuron. And then to the muscle, number 6. So there's 6 parts, I guess. I just numbered them right there. Is a stretch reflex, spinal root. Stretch reflex which was a question. What are the different parts of a stretch reflex? Okay. All the reflexes essentially work the same way. Whether there's a stretch reflex or not. I don't want to get into all the different types of reflexes, but but they work that same pattern. You need a receptor, whether it's a stretch receptor or you put your hand on a hot stove, which is a pain receptor, right? It's a sensory neuron, goes through the dorsal root into an interneuron in the gray matter, and then it goes out through the ventral root through a motor neuron, and you pull your hand away, right? Same idea. All right. There we go. I need to move faster. I'm talking too much. This is important stuff you need to know. All right. So what are we looking at here? I'm going to spend just a little bit of time here, not a lot. We're looking at how we're wired. What do you mean how we're wired? Okay. You have several pathways of how pain and touch and work and motor work. What do you mean? Let's say someone touches you, let's say someone tickles your foot or touches you on the hand. Let's go tickling the foot right here. You're going to go through something called a DCML pathway, dorsal column medial lemniscus. You don't have to really remember the names, but you just do have to remember this. It's called a DCML pathway, but when someone touches you in your foot, like tickling your foot, it's going to go through the nerve, go through the dorsal root. This isn't a reflex. It's just someone touching your foot or someone touching your hand. It's going to go through. You have receptors in your skin. They go through the nerve, the dorsal root, up the spinal cord, and then it's going to cross over at the brainstem. You see how it crosses over at the brainstem? And then it's going to go to the thalamus, right? Because remember we talked about the thalamus is the relay center of the brain. Should go to the thalamus. Yep, there it is. It's going up to the thalamus, the relay center of the brain. Then it's going to send it to the primary somatosensory cortex, right? That is how we're wired. That's why if someone tickles your right foot, it's your left cerebral hemisphere that feels it, because that information is going to go up the spinal cord, right? It's going to go to the sensory receptor, dorsal root, up the spinal cord, cross over at the brainstem, medulla oblongata in this case, but whatever, cross over in the brainstem, and then to the thalamus. Okay. Pain works the same way, but the only difference is pain, it doesn't cross over at the brainstem. It crosses over at that level of the spinal cord. It does the same thing, right? Pain, it goes through, you have sensory receptors in your foot, goes through the dorsal root, and then crosses over at the spinal cord. It's called the spinal thalamic pathway. But the question I have is that it always crosses over. Touch, fine touch, someone touching your hand, right? As long as there's pain, where does the information cross over? So let's go with Thomas. If someone's touching your hand, someone holds your hand, okay? Let's say you have a special someone. They're holding hands. You're holding hands with someone. Where does that information cross over, Thomas? If they're holding your right hand, you can feel your left cerebral cortex. Your left cerebral cortex is telling you someone's holding your hand, right? Your left primary somatosensory cortex. Where does it cross over, Thomas? Are you there, Thomas?
Yeah, sorry, I was trying to turn my mic on.
No worries.
Could you repeat the end of that? I missed the end.
Yeah, if someone's holding your hand, where does that sensory information cross over?
Is it the brainstem?
Yeah, the medulla oblongata.
Yeah.
So second part, Thomas, let's say someone steps on your foot really hard. It's painful. Where does that information cross over?
Would that still be the brainstem?
Nope. Nope, not the brainstem. Where does it cross over? Do you remember? Can someone help them out?
The spinal cord itself.
That level at the spinal cord. Now, why is that even partly important? Because that neurology is very complicated. You'll have people that, if they have a lesion at upper, let's say this happens to your foot, so it'll still happen in in the lumbar spine. This is where it'll happen, the lumbar plexus, right? It'll cross over. So if you have a lesion in your thoracic, on the right side of the spinal cord, people will feel pain, but they won't feel sensory information, right? Because sensory information goes up and crosses over the brainstem, but pain crosses over at that level of the spinal cord. So it'll go up the other side of the spinal cord if you have like a hemiplegia. So there are people that feel pain on one side, but not sensory. They're like, why is that? Well, that's because where the damage occurs and where the crossing over happens. Okay, so that does happen. Okay, so just so you're aware. So neurology is incredibly complicated because of where things cross over. Okay, now when we look at what we call the cortical spinal pathway, this is motor. Okay, let's say I want to move my foot. I'm moving my foot right now. Primary motor cortex, the pyramidal neurons, these are called pyramidal cells. These are motor neurons. These are neurons, multipolar motor neuron, very large ones. They go down the spinal cord, and they will cross over at the brainstem as well. So motor information does cross over at the brainstem. Okay, and you actually technically need two neurons, an upper and a lower motor neuron, for that to happen. It'll then innervate with the lower motor neuron, then go out to the muscle. So motor information, when you're going out, efferent crosses over the brainstem. Sensory touch information comes up, crosses over the brain. The only one that's different is the spinal thalamic pathway, which is for pain. That crosses over at that level of the spinal cord. Okay, cool stuff. All right, now let's talk about something called cranial nerves. We were talking about, these are all spinal nerves going into the spinal cord or out the spinal cord. There are some nerves that do not go through the spinal cord. Some nerves that do not go through the spinal cord, they go directly into the brainstem. They go directly in and out of the brainstem. And those are called cranial nerves. Okay, and there's 12 pairs of cranial nerves. There's 12 pairs of cranial nerves that do not go through the spinal cord. They go directly into the brainstem and then up or out of the brainstem, right? Those are called cranial nerves. And we're going to learn about some of the cranial nerves because they're important, okay? And a lot of the testing, neurology testing they do over cranial nerves. So all this stuff we talked about right now is all spinal nerves work this way for sensory, pain, and motor, okay, in and out of the spinal cord. Cranial nerves are different because they don't go through the spinal cord, okay? That's why they're special.
Question.
Yep.
For the exam, is it like knowing the name and function of the cranial nerves? Is that enough, or do we need to know their central and peripheral connections?
No, just basic information about each cranial nerve. If there's a
Okay.
cranial nerve question, it'll just be basic information about each one. Yep.
Perfect.
Yep. So we look at cranial nerves. Of course, they go in and out of the brainstem. And they start the connections, they start up at the midbrain and they start working their way down through the brain. So they go midbrain, pons, medulla oblongata. Okay? So cranial nerves, the upper, like 1, 2, 3, the midbrain, and then down. Eventually, you get to number 11 and 12. They're in the medulla oblongata, and a little bit into the spinal cord, but medulla oblongata. Okay, that's how the cranial nerves work. Okay, that's how the cranial nerves work. Now, do you have to remember each one where the connections are? Like olfactory, optic, oculomotor, trochlear, trigeminal? No, you don't have to know where each of the connections occur, okay? That is high-level neurology. I had to remember that when I took my neurology class. I guess if you ever take a class in neurology, or you do become a nurse practitioner and study neurology, right? Then you will have to know each exact one. But for us, just understand the cranial nerve is number 1. Start at essentially connect up in the midbrain, and then eventually 11 and 12 all the way down to the brainstem. I mean, at the medulla oblongata. So let's talk about these cranial nerves. Okay, here's another picture of them over here. I like this. See if there's even a better one. There's even a better one here. All right, so we're going to start with olfactory. That's cranial nerve number 1. Okay, and olfactory is used for smell. Okay, olfactory, it's sensory, and it's used for smell. So when you smell, the olfactory bulb sits at the very top of, I have to go back and forth with the pictures here. The olfactory bulb sits at the very top, this olfactory bulb sits on on your cribriform plate, nerves go down into your nasal canal. So you smell at the very top of your nasal canal, the very top, okay? And that information will travel to the brain through the olfactory nerve, which is cranial nerve number 1, okay? Cranial nerve number 2 is the optic. So you have an optic nerve going to this eye, optic nerve going to this side. They're going to come together at the optic chiasm. This is the optic chiasm. I know it's not labeled. That's what it is, optic chiasm. Optic cranial nerve number 2. So cranial nerve number 2 is used for vision. Used for vision. Optic cranial nerve number 2 is used for vision. So it's sensory. Okay. So your optic nerve, which comes right off the back of your eye, the retina of your eye, never goes into your spinal cord, right? It goes directly goes the optic chiasm and into your brain. Okay. Now, cranial nerve number 3. Okay. It's called the oculomotor nerve. See that nerve right there? Cranial nerve number 3, oculomotor. This also goes to the eye, but it doesn't go to the eye itself. It goes to the muscles of the eye. And this nerve, plus the trochlear nerve, plus the abducens nerve, okay, you'll learn about those in a minute, okay? Those are very important in motor for the eye, motor for the eye. So oculomotor is more important than the other ones because it does the most of the muscles for the eye. So if you go back to the PowerPoint here, oculomotor goes to muscles of the eye. Okay, it goes to, you have, we call it superior rectus, inferior rectus, medial rectus, lateral rectus, and you have a superior and inferior oblique. Okay, so you have essentially 6 muscles of the eye. Okay, you have 6 muscles of the eye. It goes to 4 of the 6 muscles. It goes to 4 of the 6 muscles. Now, which of those muscles you don't really need to know. But your eyeball has a superior. So your eyeball has muscles that touch the sclera. Here's a superior rectus, inferior rectus, lateral rectus, medial rectus, and then you have an inferior oblique and a superior oblique. Okay. Now, the oculomotor nerve, cranial nerve number 3, controls 4 of these 6 muscles. So it's the most important one. Okay. Now, olfactory, cranial nerve number 1, easy to test. Optic, easy to test, right? Does someone, right? Easy to test the optic nerve, right? Can someone see or not? If someone can't see, it doesn't have to be its optic nerve, but it could be optic nerve, right? Someone can't smell, is it damage to the olfactory nerve or damage to something else, right? But that's how you test olfactory nerve. How do you think they test the oculomotor nerve to make sure that's working? Cranial nerve number 3. How do you think they test that?
The
You should know that.
follow my finger thing they do at the doctor?
Yes, that's exactly what they do, right? When they're doing these tests, they're testing cranial nerves. Yes, testing cranial nerves. They're also testing the muscles, make sure the muscles work together correct, but they're testing cranial nerves, right? So when the doctor, the nurse practitioner says, keep your head straight, follow my pen or my finger to see if your eye moves, you are testing the oculomotor nerve. You're testing the trochlear nerve and the abducens nerve, mostly oculomotor, because oculomotor is 4 of the 6 muscles. Okay, and if it's a problem, then you have to follow it up. Is there a problem with the cranial nerve? Is there a problem with the muscles itself? But that is what you're testing, right? It's important to understand what is going on here, right? Why are you're going to be doing these one day. If you continue on with this in the healthcare field, you're going to be doing these one day, right? All right. Oculomotor nerve, cranial nerve number 3, okay? Next one is the trochlear nerve, cranial nerve number 4. Cranial nerve number 4. Here's a trochlear. Now, you do not have to remember the exact connections. I had to, right, when I was in school, but you do not have to. You do have to know the name of the nerve, and not their exact. See how it's starting to move down the brainstem as we go up in numbers? So here's the trochlear nerve. Here's cranial nerve number 4, trochlear nerve. Trochlear nerve does one. We call this the superior oblique muscle. Not important. But trochlear nerve does motor to the eye. Does one of the nerves to the muscles. Okay, that's trochlear nerve. Next nerve. So we went over olfactory, number 1. Optic, number 2. Oculomotor, number 3. Trochlear, number 4. Now we're going to go over number 5, which is the trigeminal nerve. Okay, the trigeminal. It's called trigeminal, okay, because it has these 3 connections. It has 3 parts, V1, V2, and V3. Okay, and when we look at this trigeminal nerve, okay, it is sensory and motor to the face. Okay, sensory and motor to the face. So let me show you a picture of the V1, V2, V3. Let me go over here. Let me find trigeminal nerve. Trigeminal nerve, where is it? Let's see if it shows it. Okay. So the trigeminal nerve is sensory, but I'm trying to find the pattern. Aha, here's a pattern. Here's the V1 branch. Here's the V2 branch. Here's the V3 branch. It shows you sensory for those portions of the face. Okay, sensory for those portions of the face. So if a neurologist says, do you feel sensory on the forehead, on the lateral, on the inferior? Okay, if that is what they are testing, is this trigeminal. Trigeminal nerve goes right near the parotid gland. So sometimes if the parotid gland is inflamed or if there's a problem with the parotid gland, it could put pressure on this trigeminal nerve. So I think that's what this person is trying to treat, neuralgia treatment. Okay, has pain along the parotid gland would sit right there, right in front of this trigeminal nerve, where it splits up into 3 branches. Okay, but it's sensory to that face. Okay. It also, trigeminal nerve also does the muscles of mastication. Chewing is trigeminal nerve. I know it's not said here, but it does. Muscle of mastication, so chewing. Okay. Okay, so are we good so far? All right. So getting back to that PowerPoint, trigeminal nerve, okay, sensory and motor for chewing. Okay, mastication, muscles of mastication. Okay. Cranial nerve number 6 is abducens. So there's 3 nerves for movement of eye. Ophthalmic, cranial nerve number 3. Cranial nerve number 4 is a trochlear. Okay, and then cranial nerve number 6 is the abducens. Where's abducens? Should be here somewhere. I'm blind, I can't really see very well. But it would be here. I don't see it listed here anywhere. But
it's at the top right.
All right. Oh yeah, there, top right. Okay. Does that say abducens? It's hard for me to see. Let me get my glasses. Here we go. Abducens. Here we go. There you go. Abducens. That is the 3rd cranial nerve for motor. So when someone says keep your head steady and you follow your eye, follow the muscles, move your eye. So you follow your finger or a pen, tip of a pen, right? That's abducens. Now, oh yeah, look at this. I should have shown this picture. See the branches? You see the branches, the V1, V2, and V3 branches of the trigeminal nerve. Very cool. Okay, next nerve is cranial nerve number 7. Is facial nerve. Let's see if I can find it. Yep. All right, here it is. Facial nerve. Got my glasses. I can see better. Facial nerve. Facial nerve is motor to the face. So let me get that PowerPoint up. Facial nerve is motor to the face. So when you say blink your eyes, right? You blink in your eyes, smile, right? Those nerves are doing motor to the face, all your facial expressions, except for chewing, mastication. Chewing, the temporalis muscle and the masseter muscle is controlled by your trigeminal nerve. So trigeminal is sensory to the face plus the muscles of mastication. Facial nerve is the is motor to the face. Okay, motor to the face. Okay. Facial nerve also controls salivation, your salivary glands. That's facial nerve as well. Okay. Are we good there? Facial nerve, I also believe, I'm trying to think back from my neurology days, also believe it's taste for the anterior part of the tongue. Facial nerve. All right, cranial nerve, so that's cranial nerve number 7, facial nerve. Now the next cranial nerve number 8 is called the vestibulocochlear nerve. Let me see if I can find it. Cranial nerve number 8. Okay, this book calls it vestibuloacoustic nerve. I never learned it vestibuloacoustic. I learned it vestibulocochlear. See, vestibulocochlear, cranial nerve number 8. Maybe that's a newer term, vestibuloacoustic, for cooler people, but I learned it as vestibulocochlear, but I guess there's another term. Maybe this is more of this is something that's really current. Okay, but I learned the vestibulocochlear back in the day, cranial nerve number 8. Okay, so this says vestibuloacoustic. What is vestibulocochlear used for? Vestibulocochlear, there are 2 nerves. If it's one nerve, vestibulocochlear, that splits into 2 nerves, and that is used for hearing and balance, because it goes to something called your vestibule and your cochlear, which is cochlear is used for hearing, the vestibule is used for balance. So that is for hearing and balance, vestibulocochlear. Okay, I don't know what vestibuloacoustic, that's throwing me off, but I'm going to say vestibulocochlear because that's how I remembered it when I was in school, so I'm going to use that. See, vestibulocochlear. It's used for hearing and balance. Okay. Are we good with that idea? All right. Glossopharyngeal. Okay. Glossopharyngeal is used for swallowing, the superior, middle, and inferior pharyngeal constrictors. So cranial nerve number 9. Let's see if we can find it. The glossopharyngeal, here it is, cranial nerve number 9. Okay. It is used for this whole idea of swallowing, right? When you swallow, those constrictors are on glossopharyngeal. Okay. So how does someone test, going back to the facial nerve, okay, cranial nerve number 7, how does someone test that? Well, cranial nerve number 7, blink, move your lips, right? If you can move the motor to your face, that's facial. How do you test vestibulocochlear nerve? Simple. You ask, can you hear this? If you can hear it, that means that nerve must be working. If you can't hear it, doesn't mean it's damaged. It could be damage to the nerve. It could be damage to your inner ear. Could be damage to your eardrum, right? It could be damage to the middle ear bones. Could be many things. But if you can hear something, sound, that vestibulocochlear nerve must be working. Glossopharyngeal nerve, how do you test that? Well, that's swallowing, right? Cranial nerve, when we look at cranial nerve number 9, glossopharyngeal nerve, that's swallowing. So can the person swallow? Yes, then that nerve must be working correctly. Okay. Are we good with that idea? Now, cranial nerve number 10 is the vagus nerve, or the vagus nerve, I like to say, although it's not spelled like Vegas. Vagus nerve. Cranial nerve number 10 is probably the most important of all the cranial nerves. What do I mean by that? Cranial nerve number 10 controls, that's the parasympathetic nerve. You can think of it as a parasympathetic nerve. Rest and digest. It goes to your digestive organs. Right? It goes to your digestive organs. Okay. Why does that matter? It matters because this vagus nerve going to your viscera, going to your heart, going to many of those things, okay, connects in your brainstem. So why does that matter? Because the nerves that tell your heart to beat, the nerves that control your digestive tract, does not go through the spinal cord. Does not go through the spinal cord. The rest and digest control of these things, telling your heart to beat. Why is that important? Because have you ever thought about it? If you cut your spinal cord below, like say your cervical spine, and someone becomes paralyzed or quadriplegic, does the heart still function? Does the digestive system still function? Yes. How is that possible if you cut your spinal cord? How is that possible? How does your digestive system still work and your heart still works and your diaphragm still works, your lungs still work if you cut your spinal cord? Someone's a quadriplegic. Because the vagus nerve carries all the parasympathetic for your digestive system, for your heart, right? Tells your digestive system keep working, tells your heart to keep working, right? Your digestive system control. I had a bagel this morning. Movement through my digestive tract is on the vagus nerve, which comes directly from the medulla oblongata, the brainstem. Does not come from the spinal cord. That's hugely important. That is why, and I've heard people say this. How come the person can still breathe? How do the other organs still work if you cut your spinal cord? Because the control of your digestive system, the control of your heart is on the vagus nerve from the brainstem. Comes off at the brainstem. Yes, if you damage your brainstem, then you're dead because the vagus nerve won't work. And of course, your heart won't work, your diaphragm won't work, your digestive system won't work. You're dead. But if you damage below the brainstem and spinal cord, you could still live because all that information travels on the vagus nerve. That's why I can call it the most important nerve, right? Cranial nerve number 10, hugely important. So now you know why, if someone's like, well, how's that person's heart still able to beat? Or how's that person's digestive system work if they cut their spinal cord? Well, because that stuff doesn't travel in the spinal cord. You should have had a better A&P teacher. You should have had Dr. T to explain that to you. It travels on the vagus nerve. So, people watching the recording, and when are you going to answer this question for them? Why is the vagus nerve so important? Because, and what number is the vagus nerve? What number is the vagus nerve? What number cranial nerve is it? And why is it so important? And I'm going to have someone in class explain that, and the person in class that's going to explain it is going to be, let's go with Amy Molyneux. Amy Molyneux, your time to shine to teach my people watching.
So it's cranial nerve number 10.
Yes.
Right? And it's
Yep.
so important because it works directly with like the organs and things. It doesn't go through the spinal cord.
Yes, your digestive organs, your heart.
Yes.
All telling your heart to beat, 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 beat. That is vagus nerve, which is a cranial nerve. Does not go through the spinal cord. So if you have a patient and they sever their spine at like C7, which is still pretty high up, right? Their digestive system will still work. Their heart will still beat, and they'll still be able to breathe. Their kidneys will still function because that is all on the vagus nerve. It's a pretty ingenious system. So if you damage your spinal cord, you'll still live because of that vagus nerve. Will still control all those other things. Really cool stuff. All right, so that is the answer to that question. Very neat. Excellent. So that is cranial nerve number 10, okay? Now, cranial nerve number 11 is called the spinal accessory nerve. Some people just call it the accessory nerve. The technical term is spinal accessory nerve. And spinal accessory nerve is it's not that important. So let me get the let me get the picture from Google. So here's spinal accessory nerve. Not that important. What does it do? It controls your trapezius and your sternocleidomastoid muscles. Your trapezius, right? Your trapezius muscle actually does not go through the spinal cord. It's kind of weird. It doesn't go through the spinal cord. It uses the spinal accessory nerve. Okay? So that is spinal accessory nerve. The trapezius and your sternocleidomastoid muscle. Spinal accessory. See? Not as important. That's cranial nerve number 11. Cranial nerve number 12, hypoglossal nerve, the last one. And anytime you hear the word glossus, does anyone remember? We went over these muscles, genioglossus, hyoglossus, styloglossus. Anytime you hear the word glossus, what does that mean to you? Does anyone remember what that means?
Tongue.
What does glossus mean? Tongue. So that's exactly how I remember it. Hypoglossus. Hypoglossus is your tongue muscles. And also, it does the posterior taste of the tongue, but the most important thing is your tongue muscles is hypoglossus. You want to test the hypoglossus, move your tongue. Can you move your tongue? Your hypoglossus must be working. If you want to test to see if your spinal accessory nerve, cranial nerve number 11 is working, raise your shoulders. If you can do that, your traps are working. Okay, your trapezius muscle is working. Fine, right? All right. So if you ever have a doctor say, "Can you move your tongue?" and you say, "Yeah, I can move it," then really why they're asking you that is the hypoglossus muscle, cranial nerve working? Yeah. Okay, it's working. Okay. All right. And that class is the cranial nerves. Okay. So that is where we're going to stop. So we finished off brain, spinal cord, spinal nerves, pathways we did, and we did the cranial nerves in class. We did not get into the eye and the ear, unfortunately, because we lost a day from the holiday. We lost actually 2 days from holidays. So that is one of the problems. We talked about. It's already told you the problem when we start this 8-week class. When we have holidays that are thrown in, it really puts a wrench in 8-week class. Because really, when you have 2 holidays, it really turned this into 7-week class, right? 7 weeks of lecture, not 8. So it just is what it is. So how the eye function, ear function, kind of, you're gonna have to learn that on your own by reading the book, which is fine because I think I'm the only online teacher that teaches this class, that lectures. So all the other people take it online don't get the lecture, I believe. So I guess they all have to learn it on everything from the book, which I don't know how that's possible, but maybe they're all smarter than me, which is possible, I guess. But with that being said, you're done with lecture in BIO201, which is pretty cool. Okay. So we go over a couple of things before you take off that's very important. Of course, I want to get your 10 to get the last points in. If you have any late work, it needs to get done ASAP, because once technically the last day of class is Thursday. Technically the last day of class. If I don't get it by Thursday, I'm not grading it. What I mean by is chapter assignments or labs can be turned in late. If I do not get it by Thursday, I am not grading it. Okay, because technically that is the last day of class. Okay, so I don't want to be putting points in after the class technically ends in Blackboard, or get not put points in because I still can grade, but is getting assignments in after the last day of class and then me grading it. And then my department chair, if it happens, look at my class, be like, why are you accepting class grade? I'm accepting assignments after the class has ended, right? So usually when someone does that, I have to do an extent. There's a form you have to fill out if you give an extension to someone. So, and I don't want to do that. I'm not going to do that. So I'm giving you all the way until Thursday to get any chapter assignments late or labs late. So let me say this again. If I don't get those by Thursday midnight, right, I am not going to grade it. Okay? But I'm giving you till Thursday. And you're that late. Do not miss your exam. Do not forget to take your exam, because if you get a 0 at the end, it's going to crush your grade. So don't do that. Okay? So do not. I've had people forget. I had a runner of mine that forgot once. And guess what? He got a 0 on. He's like, oh, give me a chance. I'm like, no, you can't. You forgot to take your final. That's the 0 average. That'll kill your grade. All right. And also, thank you for taking A&P. I know some of you may not be as excited about A&P as I am, but for me, like I told you, my favorite class in school, and I used it when I was practicing. I used A&P so much, right? I just gave an example today of why understanding A&P and pathology is so important if you go into the healthcare field. So I know I get a little too excited about it. Maybe you're like, oh, great, A&P is not that great. I think it's awesome, but it really is important if you're going to. Hopefully you enjoyed the class, but if you didn't, I hope you really still learned it, because if you go in the healthcare field, it is so important for you, for your future. Okay. So thank you for taking my class. I know sometimes I can ramble on, but I enjoy teaching it. I really do. So with that being said, does anyone have any questions before I do the attendance? No one does? All right, so let me get into the attendance here. Yes, Raquel. I think Raquel.
I do have a question, but it's about one of the quizzes and an assignment, so I can ask you at the end.
Okay, yeah, we'll wait. Yeah, I always stay after for like if you want like questions not shared by everyone. So yeah, absolutely. All right. Anyone else? Oh, you, Amy, you got extra credit.
Whoa, you were great too.
Yeah. David, nothing's gonna help your grade, David.
I'll take it.
I kid around. I have no idea what your grades are. I haven't even looked at your grades. That was just a joke. Sorry, Dave, if I hurt your feelings on that one.
No, that was funny.
Yeah. So I have no idea what David's grades are, so I'm just kidding. Could you have the highest grade in the class? I don't know. But all right. So let me do the attendance, and then you guys can get on your way here. By the way, if you do happen to take my BIO202 online class, it's the same exact pattern. So if this works for you, it's the same way. If it doesn't work for you, then you know, like not to sign up. If this definitely does not work, this kind of way I have class set up, and chapter assignments and labs and exams. And thank you. I appreciate all the nice comments there. But just so you're aware, my 202 class is the same exact path. It's the same exact way. It's the lectures and then the weekly assignments, the weekly work. So it's just the format's the same exact way. So if you do take 202 from me online, then you know kind of what you're getting into. You know exactly what you're getting into, not kind of exactly what you're getting into. So, all right, stop sharing there, and let me get into the grade book here. All right, grade book. All right. Okay, so Jessica, are you here, Jessica?
Here.
All right, Jessica, your points are in. You're good. Alisa?
I'm here.
No, Alisa. Oh, Lisa's here. Okay.
I'm here.
All right, Lisa.
Yeah.
All right, Lisa. Yep. Your points are in. You're good. Why is that doing that? Now your points are in. All right, good. Raquel, you here, Raquel?
I'm here.
All right, Raquel, your points are in. You're good. David, are you here, David? I think I just saw him earlier.
Yeah, I'm here.
All right, David, your points are in. You're good. Araceli, you here, Araceli? No, Araceli. Thomas, are you here, Thomas?
I'm here.
All right, Thomas, you're good. Angelina? Faith?
I'm here.
All right, Faith, you're good. Amy?
I'm here. Thank you.
Oh, yeah, that's right. There's two Amy's. Amy Mole now. Yeah.
Yeah,
Thank
I'm
you.
here. Yeah, just to
All right.
remind you, Nelson was here too.
Okay. All right. Okay. Yep. Oh, yep.
Thank
Great.
you.
Thank you. Because I've already forgotten. Thank you. Yep. I'll make sure I get his.
All right.
Thank you. Mackenzie?
I'm here.
Yep. All right. Mackenzie, you're good. Amber? Amber? I thought I saw her. But maybe I didn't. Amber? Amy Sauer?
Yep, I'm here.
All right, Amy, you're good. Nelson is here, so Nelson, I already have your points in. You're good. Nicole?
Yep, I'm here.
Yep, Nicole is here. And Abigail? Abigail? Yep. All right, Abigail. You're good. All right. All right, so that is that. And all right, so let me hit stop record.